Our research looked at antibodies in children who are sick and urgently listed for transplantation. And historically, these children were listed and with a requirement for some testing to be done immediately before transplant that made it very difficult to do the transplant, or they just were not listed. And we've shown that strategy is not beneficial, and that in fact if you just took that first organ offer, if it was otherwise good without respect to those antibodies, and even if they wound up having a transplant, that on the whole that those patients would do better. We found that in fact it's also less costly to do it that way, meaning patients who are listed, the cost of staying in the hospital waiting for a transplant far exceed the costs that if they were to wind up with a transplant with these antibodies posing issues, that those costs on the pre-transplant side exceed the other ones. Important to point out, so this wasn't a clinical trial where we actually had patients enrolled in one strategy versus the other. We used data from the transplant registry in this country. We used cost data from another database, the Healthcare Cost and Utilization Project public database, and we put all that data into what we call as a Markov model, a decision model. So it's a computer model that then analyzed that and predicted these outcomes. It can be a consequence of their previous heart surgery. So commonly patients can have congenital heart disease and need prior surgeries, and sometimes patients have what we say cardiomyopathies that are just acquired. But if they've had congenital heart surgery and they've needed prior surgeries, or if their heart is sick and they have a VAD, a ventricular assist device placed, they can develop antibodies to other people who then are potential donors. And so it doesn't cause the problem with their heart per se, but it's a consequence of having had heart disease. We really look specifically at this strategy in children who have antibodies and just compared whether you take the first organ offered or not. I think it's a really important point that you bring up, that looking more broadly at organ allocation in general is very important. There are lots of children who don't have antibodies, and so one could make the argument, in fact, that and this is really a societal decision where you draw the line. You might say, I don't want to transplant anybody with antibodies because it's probably more costly than transplanting patients who don't have antibodies. One of the problems with that strategy is even if you don't have antibodies going into the transplant, you still may develop antibodies after transplant. And those antibodies can still be very devastating and cause rejection and cause problems. So I think that while you could say that sort of extreme case, I don't think that actually makes practical sense. And so we just need to understand the resources and limitations of what we're doing with sensitized patients with antibodies, and understand that there will be patients without antibodies as well, and probably not limit the playing field too much for the ones with antibodies, because anybody's at risk for developing those after a transplant. We struggle sometimes with whether a heart is a good match, and that's just sort of thinking about all the factors: size of the donor, the size of the heart, how sick the candidate is, are they desperately in need of a transplant, that if they don't get a transplant in the next 24 hours they're going to die, something like this. And really try and struggle with those factors. Sometimes it's very obvious. The heart is a great heart and your candidate's ready, but sometimes it is really difficult, and you have to, and this is the type, I hope this is the type of research that gives people some data to make some decisions based on, and not just rely on gut, which unfortunately is a lot of what we wind up doing. We have a lot of experience. I think that's important to not discount the experience that you have, but I think this is actually a good example of what we thought may have been the right thing to do in the past. When you do the research, sit down and look at the numbers, look at actually what's happened, as best we can tell, actually the opposite strategy is more favorable and cost beneficial. So in the current era of real-time virtual cross-matching, I think it's important to understand that we still don't understand that technology fully, meaning we get data about antibodies being present, but we don't understand at what levels or what thresholds those antibodies are actually clinically meaningful. We're learning about that. We know some things about it. Lots of antibody and what we say high titer or high MFI is probably bad. But I don't think we know at the lower end what that limit is, how low is okay versus where that threshold should be. So if we start making decisions based on any antibody being predicted by this test, as being a problem, we're probably going to start excluding patients that maybe we shouldn't have excluded in the past, and then that will have clinical ramifications in terms of who gets transplanted. And I don't think that we should take away that every highly sensitized patient must get that first donor organ offer. I think that would probably be the wrong meaning to take away from it. I think there's a few key things here. Regardless of what these models show, there's clearly a shortage of donor organs. That's huge, and I think one donor can provide 8 organs to save 8 lives potentially, and there's a certain number, and unfortunately I don't know that number, but a good number of people, about 20 people a day in this country, who die awaiting an organ transplant. So, this model has come about because of this need to kind of figure out how to best utilize organs. It would be great if we didn't have that problem.